Hello, everybody. My name is Tyler Lacoste. I'm going to be presenting to you guys on preeclampsia and eclampsia in pregnant women. So, in general, preeclampsia is the new onset of hypertension after 20 weeks of gestation with or without proteinuria. Eclampsia has the same definition but with the addition of a tonic-clonic seizure. Though preeclampsia and eclampsia is not the most prevalent complication of pregnancy, existing in about 5 to 8% of pregnancies, it is a potentially harmful and lethal one. The current running theory of the etiology of preeclampsia and eclampsia is that there is an endothelial dysfunction causing inflammation and damage from materials produced by the placenta. This theory continues to drive research in the etiology. However, the causation of preeclampsia and eclampsia remains unknown. The box at the bottom of the screen is a list of risk factors that predispose women to developing preeclampsia and eclampsia during pregnancy. Typically, at the signs and symptoms and physical exam. Typically, at the time of diagnosis of mild to moderate preeclampsia, the patient will be asymptomatic. However, with a more severe presentation of the disease, will present with headaches, visual disturbance, pain in the right upper quadrant of the abdomen, as well as nausea and vomiting. This is not limited to these, these are just the most common. Eclampsia is the most severe form of the disease and will present differently, but will always have tonic-clonic seizures on presentation. Further investigation into the patient with labs and workup may reveal worsening of internal organ function. Unfortunately, clinical presentation of symptoms varies greatly between individuals and almost always requires more in-depth examination to identify. Diagnostics. Preeclampsia and eclampsia is a clinical diagnosis and requires no official test to diagnose. Generally, women with suspected preeclampsia will undergo dipstick urinalysis test or spot urinary protein to creatinine ratio test. While the presence of proteinuria is not required criteria for a diagnosis, more than 300 milligrams per day of protein is a strong indicator of preeclampsia. Imaging is available in the form of an MRI that may show changes in the placental tissue but is not necessary in the assessment or diagnosis. Liver, transaminases, and low platelet counts may be good predictors of impending complications. Differential diagnosis. When assessing for preeclampsia, you have to rule out primary headache disorders, hypertensive disorders, hemolysis, HELLP syndrome, and liver and kidney conditions. When assessing for eclampsia, one has to rule out primary seizure disorders, cerebral venous sinus thrombosis, acute ischemic stroke, and intracerebral and subarachnoid hemorrhages. These can be assessed further with CAT scans of the head and the abdomen. The treatment. There is no current standard of care that is widely accepted. The studies have shown that prophylactic aspirin, when taken before or at 16 weeks gestation, significantly reduces the risk of developing preeclampsia, but does not necessarily prevent it. As of yet, prophylactic use of aspirin is the best prevention strategy available. Prophylactic magnesium sulfate is used in cases where a woman is at imminent risk of developing eclampsia. Magnesium sulfate prophylaxis can more than half the risk of developing eclampsia, and to date is a superior strategy to prevent eclampsia. For preeclampsia, the typical approach is to treat with antihypertensive agents with the recommendation to withhold antihypertension therapy until diastolic blood pressure reaches more than 110 millimeters of mercury. Also, gestational age at diagnosis can make the determination between disease management or induction of labor. With a diagnosis at fewer than 36 weeks of pregnancy, antihypertension therapy is considered. Labetalol and hydralazine are the preferred agents. However, methyledopa and nifedipine may also be used for hypertensive management. In the table on the right is a list of drugs that are typically used for antihypertension therapy, along with their dose, their route, the frequency, and the maximum dose they can receive in a day. In cases of severe preeclampsia, treatment with magnesium sulfate is recommended to help prevent onset of eclampsia or seizures. However, if preeclampsia or eclampsia is diagnosed closer to term, the recommendation is to induce labor since delivery is the only cure for preeclampsia. In those diagnosed with preeclampsia who are not being treated with antihypertensive agents, monitoring blood pressure is the main goal. If on antihypertensive agents, the patient is monitored for maternal and fetal status until the appropriate time has been identified for delivery. Postpartum monitoring for continuation or new hypertension and proteinuria is crucial in those with preeclampsia, eclampsia, or those at risk for developing either condition, as preeclampsia and eclampsia can extend up to 2 weeks postpartum. During this time, the patient continues antihypertensive therapy or treatment with magnesium sulfate to prevent seizures and is monitored closely to ensure the patient safely returns to normal. That is all for my presentation today. These are the list of the resources that were included in my presentation. Thank you.